Hello, everyone, and welcome to Physio Minds podcast. It's been a minute since we've had a few conversations about physical therapy, but today is going to be a really fun conversation. And if you forgot, I'm your host, Alex, and that's my co-host, Theo. Both of us have graduated since the last time you heard a podcast from us. We both graduated physical therapy school down in Miami, and we both passed our boards, and we're both nationally board certified physical therapists. So come and see us for some treatment. Uh, Theo, why don't you give us a little bit of background on where you are, what you're doing, and what kind of setting you're in?
All right, cool. What's up, everybody? So I'm currently working in South Florida in Hollywood. I work for a big hospital system over there for their outpatient rehab facilities. So I see a lot of ortho, but it's more outpatient general. So I see a lot of neurological cases, strokes, a lot of spinal cord injury. We see vestibular, post-op, general deconditioning, balance, whatever. We also have a pediatrics department, so we see that it's a huge hospital, which is great for starting my career there because there's a lot of mentorship. I see a lot of cases, so I'm using everything that I learned in school, which for me I think it's important to I paid so much money for school to learn all these things, and I want to use all the things that I learned, right? Like I don't want to just use the 30%, which is orthopedics or whatever it is. So yeah, it's great. I love it. I work 4 10-hour shifts, so I have one day a week off to kind of do what I want to do. And it's great. One patient at a time, 45 minutes, 45-minute treatments. So it's awesome place to like practice my skills for in terms of manual therapy, facilitation techniques, things like that. I'm one-on-one with the patient. So, it's great to like see the patients get better as you're working with them.
Nice. Yeah, and being with such a bigger hospital system, you get to interact with more physicians and other physical therapists and other healthcare professionals, which is really nice to see. Um, for me, where I work right now, so I'm in a very cold state right now in Illinois. So I'm in Chicago, while Theo is in sunny Miami, Florida.
It's nice over here.
Yeah, dude, it's like 20 something degrees here. It's supposed
It's
to be.
81. It's 81 over here. So
Yeah, big jealous, big jealous. But for me, we interact with physicians. I'm in an outpatient balance slash orthopedic um, clinical setting. And what you see from us is we actually go to physicians' offices, talk to them, and actually bring in the patient. So for us, it's a little bit more marketing that we have to do with my company. Currently, I'm in the Buffalo Grove, Illinois area. And that's where I'm practicing out of. But for Theo, real quick, you said you see your patients between 40, 45 minute sessions, right?
right.
So how many patients would you see a day approximately?
So I see one patient at a time. So it's only 11 max. 11 max patients a day because I have like an hour for lunch. And then it's max 3 evaluations per day, which is also nice, because I know sometimes we get loaded with these evals, and you stay till late documenting, and
Yeah,
there's no quality of life there.
I agree, man. I agree. I don't know for you, but I think the hardest or the most difficult eval is usually at the end of the day because
Oh
you've
yeah.
seen a full caseload, right? And then now you have your last eval and you're like, okay, one more evaluation. And it's never simple. It's always throwing me through a loop.
Yeah, there's always like some psychosocial component or that it happens, but you gotta be prepared. I like to have a little coffee right before my last eval. I'm like, all right, I already know what's gonna happen. Like I'm gonna have a little coffee, give me a little bit of an energy boost to be able to like handle, you know.
Yeah. No, I totally agree with that because it for me it never fails that I always have something going on. I'm just going to share a quick story. One of my first evaluations working with this company in Illinois is we see a lot of balance, orthopedic, vestibular is like one of our big things that we see, vertigo. And I was trained in my clinicals to treat vertigo and vestibular patients and balance and all that. And when I saw this patient, it was my first week of work. It was the last patient on a Friday, and it was 4 p.m. And I'm like, oh man, I hope this patient's okay. I hope it's not as, difficult as it may be. And God bless this lady's soul. She took it like a champ. And when I was doing the Dix Hall Pike maneuvers and I was doing Epley's on her, um, she was probably one of my most symptomatic patients. And she did throw up. And I was like, man, I feel horrible. And I'm a new clinician, right? So I'm like, oh my God, I hope this lady's gonna be okay. And then once she left, I was like, is she gonna survive the weekend? Is what I thought. Because I was like, what if there's something else? Everything's going through my mind. And it's like when you're the evaluating therapist, you're looking at your central signs, you're looking for peripheral, you're looking at everything to make sure like she's okay and it's truly vertigo. And it kind of the reason why I'm saying this is that after I treated her that Friday, I see her on Monday or Tuesday, and she comes back and she's hugging me. She's so happy. She's like, I couldn't believe that after 24 hours afterwards, I was walking, I was normal again. And I was like, oh my God. All I kept thinking was, I'm just glad you didn't die because I thought I thought I did something on Friday to like really throw her through the loop. And
Um,
yeah, that was an experience,
you know,
man.
my takeaway from that is just make sure every time you're doing that, you're treating someone dizzy, have a trash can next to you, next to that treatment table. You don't want to be cleaning vomit off the floor, you know.
Oh, you don't. And man, I never ran so fast in my entire life. And I was like looking for a trash can. I gave it to her, and you can be as prepared as you want, but in the end, if it's not right in front of you, it's just like game over.
Yeah.
um, but with that being said, how do as a new clinician, you should be looking at your patients after you evaluate them. And then let's say you do a treatment option, right? So you do some type of intervention. Let's say, for example, it's turning my head to the left. Okay, I can only get 50 degrees. Okay, well, let's do some soft tissue and whatnot. And maybe you want to do some mobilizations. But what can you do beforehand, right? Which is assess the patient like we did. We say the patient goes to 50 degrees. And then the biggest thing to do is reassess. So see if your techniques or interventions are working. Theo, I
Yeah.
don't know if you have any
No,
advice on
that's I live by that. So I have some students that come in through my time as and granted, I'm a new clinician, and in that time, I've been lucky enough to also like work with students and do a little bit of mentorship. And that's what I always say, like assess and reassess. And they're like, "Oh, I did this intervention." I was like, "Oh, did you assess and did you reassess?" Like how do you know your intervention's working? Like how do you know like this is what they need, right? Because a lot of times they teach us, okay, you're gonna do this technique if they're lacking range of motion for this rotation, whatever. And then we do it and we're like, all right, next intervention. It's like, okay, like hold up, right? Like first of all, not every intervention is as effective. And second of all, it might not be as effective. It might be effective 99% of the time, but it's effective for this patient.
right?
And so I find it like really important to, assess whatever it is, pain, range of motion, strength, motor control, whatever it is, do your intervention and then reassess after it, right? So like a lot of times, for example, if someone comes in with 140 degrees shoulder flexion, and granted, we know normal is 180, whatever. And then I'm thinking, okay, the thoracic spine is at fault. So let me work on the thoracic spine. I do mobilizations, I do an exercise, whatever. And then after that, I retest, right? Like, okay, was I right in my thinking? Like, did what I do help this patient? So I reassess. And then if range of motion improves, whatever it is, I document that. One, showing off my skills a little bit that I know what I'm doing,
Of
which is
course.
important, right? Two is also the patient buy-in, right? Like patients see that and they're like, okay, like one, this guy knows what he's doing. Two, it's also like, all right, like I know this exercise that I just did is going to improve my shoulder range of motion. And I understand why I'm doing what I'm doing. And that's going to increase the buy-in to like allow the exercise, the patient to do the exercise at home, because that's our biggest battle, getting them to do their home exercise program, right?
Hmm.
So again, I think that's test and retest, live by that.
Yeah, I 100% agree with that, Theo. And the crazy thing is for PTs is that they might not realize it, or maybe they do realize it, but you are always, from a business perspective, I'm looking at it, you are always selling the patient. That isn't only during the evaluation, right? So your patient, you can say, I did my evaluation. I want you to come 4 times a week, 3 to 4 times a week, and for 8 weeks, let's say. But they might look at it, well, that's a lot. Why would I need that? You convince them, you say, I think this would be better, blah, blah, blah. 2 weeks down the line, they might say, oh, I'm feeling better, I'm done. As a PT, like I think the assess and reassess is a good measurement tool to say, okay, hey, this is where you are. This is where you were. And every visit, you have to say, okay, you can move a little bit more. You can move a little bit more to the left or to the right with your neck or whatever it is. You start off with a yellow TheraBand, now you're to the red TheraBand, and before you couldn't even do one repetition. So it's always telling the patient, like, we're always quote unquote selling them. I hate to use the business stuff, but it's stuff that, they don't tell you in PT school. And each visit is, hey, you're doing better, you're doing this, you're doing that. And you have to show them that, because some people might not see the smaller victories as much as we do. Because, like, for me, if my patient was walking, if my patient came in a wheelchair and I got them to walk handheld assist by after 12 sessions, that's a victory for me. I mean, for them, that's a huge thing. They're like, oh, the other day, my leg is still hurting. I still can't walk perfect. Right. But I'm like, hey, like, this is one of my patients that actually did do that. She uh, came in a wheelchair. I got her walking on a rollator. On her rollator, I got her walking with a cane, and now she's walking handheld assist, and now she's walking with supervision. I mean, it's little things like that. There's always little victories. The
Yeah.
first day she walked 60 feet. The next 3 sessions, by that third or fourth session, she was walking 200 feet, but had to sit afterwards. Doesn't matter. That's a big difference, 60 to 200.
Right. And that's why also I love progress note day. Hate the documentation, don't get me wrong, but I love
Me
like
too.
seeing the progress that the patient's made, like showing them the progress, like, hey, like look, like this is where you tested last time for this test. This is where you are today. And then
Mhm.
I'm like, oh wow, that's a big difference. And I was like, and then I like to put it on them. Like, I'm like, okay, like this is all you, right? This goes to show like this is a reflection on your commitment to the program and like your commitment to the exercise at home, because all I'm here to guide you, right? But if I prescribe exercise and you don't do them, you're not going to see the results, unfortunately. um so progress note day is important, but it's not just shouldn't I don't believe assessment should only happen on progress note day. Like you should be able to tell if you're going the right track, right? So like I'm treating this patient now, and I've been treating her for headaches, and I've been working, neck, subcranial, whatever, all that stuff, what we learned in school. She's not getting better. Granted, not super consistent with her exercises, not super consistent with her ergonomic setup and stuff.
Mhm.
But then I kind of stopped, and I was like, okay, like it's been like 8 visits now, whatever. Like things haven't really been getting better. Like, it's like, let's reassess what's going on. So I take a step back, I reassess her posture, and then I notice that her posture alignment, she's like side bent in the lumbar spine, rotating the thoracic, and then side bent to compensate at the subcranial spine. So I I was okay, like let's try something different. Let's work a little bit on your low back, right? Your hips, your pelvis, like realign, because we've been working top to bottom. Let's work, bottom to top, right? So
Mhm.
I worked a little bit on her spine, fixed. I treated what I find, right? So I treated the low back, treated the thoracic rotation, and then I worked on the subcranial spine, and I had her stand up again, and she was in like perfect alignment.
Mhm.
Haven't seen her since. I don't know if the headaches improved or whatever, but like, you know, even in that one treatment, I was like, okay, like let me. I think it's still important to like like take a step back and like you might believe what you're doing is great and it's working, but like every patient is different. So always reassessing. It wasn't a progress no day. It was just another like regular treatment that I was like, okay, like like this isn't working. I got to take a different approach. And I was humble enough to realize that I'm not always right. You know, um, you gotta and again assess, reassess, right? Like, did my I checked her posture initially, and then I put her incorrect posture. She did not like that. Didn't feel good. So
Hmm.
then, when at the end of the session, she was able to maintain correct posture by herself without really any like tactile cueing from me. So I take the win. You
Yeah.
know, again, for her to maintain that, she has to do her exercises. Which did she do it? Probably not. Based on history. But I'm hopeful. I believe in my patients. One day she's going to start doing her exercises. Things are going to get better, and it's going to be all good.
Yeah, I like that. I like that. It's like you said, it's the small victories um, that are honestly like that we see all the time, and that's what we really look for. And you actually brought up a really good point is you don't have to wait until the plan of care or the progress note, in order to uh, do something different, right? If you're seeing your treatment's not working, try something else. For me, I'm like after I don't know how many visits would you say until like you see some progress, but maybe after like 2.5 weeks, you
I
would
think
say?
it depends on what's going on, but for me, typically, I see the patient starts to feel better like at 2 weeks.
Yeah,
I mean, you can also get a patient feeling good if it's strictly a mechanical problem. You can get a patient feeling good day of.
right,
But typically, I think it takes 2 weeks to really be feeling good consistently.
right, right. And I wrote this down is like if your plan of care that you made is not working, you have the ability to change your direction of treatment, right? So as a PT, we're able to do that. I think for PTAs, I could be completely wrong on this, but they're following the plan of care that we write up,
But
and then the physician signs for it, right? So we write the plan of care, we send it to the physician signs it, says, okay, this is good, and then PTA just follows it. But I do have to say, PTAs are really, really key for physical therapists. And it's really essential that you continue to communicate with your fellow therapists or PTAs or just therapists in general about the patients that you share. So, for example, I may share a patient with Theo, and then I may share a patient with, let's call him, I don't know, Jack or something, right? So, whenever I write my plan of care or when I'm doing an evaluation, I'll always try to introduce that therapist if they're around and say, hey, so and so, this is Theo. You're going to be seeing him and me for your treatment, and we're going to collaborate together and talk about your sessions. Every session or every other session, and kind of just communicate. So constant line of communication is essential, especially if you have someone else's um, patient. I don't know if you have
Right.
anything more to
No,
say.
and just to like follow up on that, I think it's also important to have multiple eyes. Like if you can, right? Like if you have that like luxury, having like a therapist that you trust looking at your patient and like hey, like I'm concerned about this patient. Something isn't seeming right. Do you mind coming in, checking? Like see what you think. Let's compare notes, type thing. And I think it's great. Like it's also kind of like it's a team thing, right? Someone else, like Alex might catch something that I didn't see. I might catch something that Alex didn't see, and that way the patient, and that's how I sell it to the patient too, because they're like, oh no, I really want to see like one therapist consistent. I'm like, look, like I understand that, but I think it's important that you have, I don't want a big team. I think two therapists, max three, honestly, and that so that the patient one has a consistent plan that they're following, and two, multiple eyes on the patient, seeing things. Someone has to catch something that's the other person didn't catch. So anyway, I'm gonna leave it at that.
Thank you, everyone, for listening to Physio Minds podcast. Be sure to like our Instagram and like our Anchor and Spotify podcasts. And what we're going to talk about next time is what happens after you graduate and what do you want to continue after PT graduation, especially when you just started into the workforce. So thank you guys very much, and we'll see you next time. Theo?
All right, thanks everybody.